Welcome. It's so good to see you here on December 2nd here. Good morning and welcome to Primetime at BU Library. The Friends of the BU Library collaborates with faculty development and other offices on campus to bring you programming that celebrates learning in and beyond the classroom of Bethel faculty, students, and staff. We're so glad you joined us today. This is our last Primetime of the semester. Watch the Bethel calendar for presentations beginning again in February. So today we have a team here. A team of Bethel graduates who have been working directly on the front lines, and they're going to share with us today expertise and experience in COVID care of patients. And we also want to point out that we have a drawing for chocolate. So if you got your ticket, then Nathan can explain to us the plan here.
Yeah, so I think I tried to catch most of you on the way in. So if you write your name on this little ticket stub and drop it in the bowl that we have back there, we'll do a drawing at the end for some more chocolates. And then if you take the other side of the ticket with you to health services to go get a vaccine or a booster, you can get a chocolate there too. And if you already have your vaccine and booster, you can give it to your friend and make a chocolate. So.
Thank you. Okay, so let's introduce our panel today. And I'll just start off. I'm Dr. Kristen Sandow, and I teach in the nursing department here. I'm a Bethel graduate, and I got my master's and my PhD at the University of Minnesota. And I worked for over 30 years in acute care, dealing with cardiovascular and infectious diseases. And it is just a wonderful boost to have our graduates around me being able to share information with you and talk about some things in direct care that I don't have as much experience with. So I'd like to just quickly introduce our other moderator. I'll let Nathan introduce himself.
So I think most of you guys know me. My name is Nathan Hoff. I'm a senior nursing student. I'm in BSNA, and I spent the summer and this J term I'll be working in the surgical ICU over at the U. So I've had some COVID experience thus far.
Okay, I'm going to turn to my left and I'll let each panelist introduce themselves as well as our panelist that is joining us from New York via Zoom.
Go ahead.
Hey, my name is Liz Miller. I'm Director of Health Services and a Bethel alum as well. I was in the very first graduating class, nurses. That was a long time ago. I have been in college health for 20 years and my role with COVID has been primarily, serving on the COVID response team, but doing a lot of testing and a lot of vaccinations. I also work in home infusion therapy, and I can't remember when it was, maybe November of last year, I was doing a fair amount of the IV monoclonal antibodies, which was very interesting. And then that went away. The company I work for had a brief contract with the government. So that's my experience.
Yeah, my name is Anna Watkins, and I graduated from Bethel just this last spring of 2021. And I work in the medical ICU at North Memorial as a nurse there since August.
Hi, my name is Brittany Anderson, and I'm a nurse, Bethel grad from 2019. I work at the U of M East Bay Hospital on the general medicine unit that has adapted into the COVID unit. So I've been working with COVID patients ever since March of 2020.
My name is Jillian Drewes. I am a 2018 graduate of Bethel's nursing program. Since then, I have obtained public health nurse certification and board certification in critical care nursing. And I have had some really interesting unique opportunities, just kind of how it just fell. Currently, I work at Unity Hospital in Fridley, but prior to that, for quite a bit of the pandemic, I was working at Mayo Clinic in Rochester, and I worked in medical ICU there doing care of COVID patients on ECMO, advanced forms of life support, as well as phone triage, and I also still serve occasionally as a volunteer at the state's medical reserve corps, including vaccination and testing.
Okay, Dr. Brueske from New York.
My name is Ben. I initially went to nursing school at Bethel University. I graduated in 2000 and I think it was 12 now. And then I worked at Mayo for 3 years in their cardiac ICU, and then I went to med school in Albany, and now I'm out in New York right now at Columbia doing my residency in anesthesiology.
Thank you so much. So now we are going to just kind of go into asking people if they wouldn't mind sharing. Here's their photos for those of you if you couldn't see them, if you were in the back row then. Here's our photos again. So our first question today is, would you share a story or two of your experiences working on the front lines? We have a couple photos that will help those of you who aren't familiar with critically ill patients in the hospital, and now you haven't been able to even enter or visit a hospital during the COVID pandemic for a long time. So we just have a couple illustrations that will help you maybe understand what is going on in there. So who would like to start?
I can start. We were talking just before this started about, sharing stories and how we couldn't really think of any poignant stories at this point because it feels like every day is just that poignant story. So it's just another day at work. I remember, I worked as an NA in our ICU my senior year of school. I worked 3 nights a week, which was crazy. I don't know why I did that. It taught me a lot, and I worked through the beginning of the pandemic that way, and I remember stapling the straps back on my old N95s because I had to use them until for 10 or 20 shifts, and I'm just sitting there stapling, thinking this isn't normal. We recently cared for a patient who was younger than me who had COVID and was prone and paralyzed and had a kind of typical COVID course, and I was praying for her recently, and she was starting to wake up and was just calling out for her mom and wanted her mom to be there. And I just so resonated with that. When any of us are sick, I remember being sick my freshman year of college, and I was had a cold, and I was so sad, and I wanted my mom to be with me, and that's so much worse. And just thinking about how her mom can't visit her. Just stories upon stories of being right there before someone's getting intubated, and then saying I wish we would have got the vaccine, or make sure you say hi to my family, don't let me die. All those stories that feel just so routine at this point that shouldn't feel routine.
I'll share too a little bit about this picture. So this is an example on the internet thanks to ACRE magazine, because I don't obviously have a picture to show you of a patient that I transported out in this position, but frequently at Unity we find ourselves in the position of having to send people out for a higher level of care. So they need something that we can offer them, like continuous dialysis, or if they're an ECMO candidate for that advanced life support, or if they need even a tracheostomy, so where they've been on the ventilator for a long time, we think we're going to be able to wean them off, and they'll be able to breathe on their own again, but we can't just pull out the tube and it's going to damage their vocal cords and some of the other surrounding structures. So they have to have a surgery that places a breathing tube a little bit lower down from the outside through the neck rather than through the mouth. And I had a patient who is not much older than I am, who I had to try and transfer in that position. And it took quite a few people. We've gotten it down to a science, I think, where we can, depending on how big someone's body is, get them into a prone position with 4 people. But we're a 10-bed ICU at Mercy, so finding 4 people can be a challenge sometimes. And we were at shift change. We were trying to ship this young patient out to another hospital to get the care that they needed. And we had to make sure that we could find an ambulance crew who could transport someone in this position. And it's one thing as a new nurse to take care of somebody who is really, really, really sick. And I've gotten used to caring for patients who have COVID in some ways, heard a lot of last words, heard a lot of regrets, been the hand to hold it in someone's final moments. And I've gotten way more used to that than I ever thought I could and that I would ever want to. But what strikes me is that people are getting sicker, younger, and it's taking so much to try to care for people, and we do our best, but we lost a patient recently who's my same age earlier this week who had not been vaccinated, and they have since passed away.
I think when I was reflecting on what story I could share today, I wanted to share one of the first stories that I encountered that kind of was kind of a big wake up, like, wow, this is really severe, and you just don't know when it's going to be that severe too. I was working a night shift, and we got a patient transferred out from the ICU, and I got a chance to hear a little bit of his story. And so I work at a general medicine floor, so when patients are down in the ICU and they are no longer needing that intensive care, they can transfer up to us. But what I heard from his story is he was right around my age. He had just graduated from college, and he was out celebrating with his friends, and just they went around the town a little bit. And next day, he developed some symptoms. He got tested, was tested positive for COVID, and in the next 2 days, he was in the hospital. And it started with just needing a little bit of oxygen support, and that progressed into needing a machine called a BiPAP, and that forces air into your lungs because your lungs aren't healthy enough to do it themselves. And that kind of led to him actually being intubated and in the ICU for weeks. He got back up to us, and he was nearing heart failure. His kidneys were not functioning at the level that a 20-some-year-old kidney should be functioning. And he knew that he had a long course ahead of him. He ended up transferring them to an acute rehab unit, which is where they do pretty intense therapy, like for hours a day, just to regain strength and whatnot. But he had, before COVID, been a healthy young person. And after COVID, he had so many comorbidities. And that was kind of the first time that I realized, like, oh my goodness, he is my age, and like this could happen to me, happen to a young and healthy person. There's just no way of knowing with COVID. So yeah, that was kind of one of the biggest shocks was when that happened.
Thank you. When you say the word comorbidities, in case anyone's not familiar with that, that's many different illnesses or challenges. And so it's more than just a respiratory virus. It can affect different organs in the body. So, and I think maybe Dr. Bruske, did you want to share a recent story that you had to help people get the picture?
Yeah, I was just going to mention, and it's probably fairly in line with most of the other stories that people were just sharing. It's kind of the surprise that you have when you realize how young some of these patients are. What came to mind for me was, kind of eye-opening. There was this 35-year-old woman. She had her husband in the hospital, and she was initially doing very well. She came with some shortness of breath, but then one day she just acutely got worse. And it was kind of just standing at her bedside trying to figure out what the heck is going on. She got clots in her lungs, and there are a couple conditions that can cause blood clot in the lungs, things like that. And the most common are like anticoagulant medications. The reactions to that can cause things like this. In her case, though, it turned out it was actually a post-COVID coagulopathy. So basically, her body just kept producing clots over and over, and she kept intermittently bleeding or clotting. And it was frankly kind of terrifying to see in this fairly young person, and trying to console her husband when it's just him and his kids. And I don't know, it's a very hard thing to deal with in someone that age, and it's not something that you anticipate happening. And talking with the hematologist or the blood doctor there, she was talking about how this is not uncommon for her to see lately. This is, a fairly, known side effect of COVID specifically is like a coagulopathy afterwards. And, it can hit people no matter what their age is. So that was kind of very eye-opening for me, seeing that, firsthand with someone that age.
So I think Nathan is kind of fresh to the intensive care. And so I asked him to explain a little bit about these pictures, because those of you who aren't familiar with words like ECMO and hypercoagulopathy might appreciate some picture explanations.
Yeah, so my history kind of before school, I worked as an aide on a ventilator unit for a long time. So I got very familiar with breathing tubes and ventilators. And I think that's what most people hear about when they hear someone's in the hospital with COVID. They have a breathing tube, they have a ventilator. And obviously that's not fun. But then I was in the ICU and I learned about what ECMO is. And I think that's something that I had just never heard of before COVID, before being in an ICU. So I just wanted to take a second to explain what that is and just the impact that it had on me. So ECMO stands for extracorporeal membrane oxygenation. A lot of big words. So it just means it's a system that takes the blood out of the body and puts oxygen in it and puts it back in. So if you think about it, a ventilator is making the lungs expand, and so air can come in. ECMO is what's actually getting the oxygen into the blood. So those are the two functions that your lungs really do, is getting air into the body and then getting that oxygen into your blood. So what I realized is you see these patients that have these ECMO cannulations. So in these pictures, the right side is a north-north cannulation and the other side is a south-south cannulation. So they've got these giant vessels that look like small garden hoses that are going into the large vessels of the body to circulate just liters of blood. And it's wild to see. Like, there's no way that I can explain the feeling of walking into a room and seeing two machines that are acting for someone's lungs. You walk in and you see a patient on these machines and you just go, oh, their body isn't working at all, to the point that these lungs can't serve either one of their functions. And I think that just really hit me as someone who's gone through nursing school and thought I would have an idea of what this might be like. And then you see it in person and it really affects you. So kind of what some of these ladies have said about doing things that you'd never think you'd be comfortable doing and holding people's hands as they're dying and stuff like that. Take care of your nurses in your life because they need it.
When I talked to Nathan earlier, he mentioned when you first walk in that room, it's like you're seeing a body. It's a body, and where's the rust? Where's the soul? Where's the humanness? And I know I've heard too from the others of you that it feels like this is just every day, day after day. And so when Nathan is saying, take care of your nurses, take care of your aides, your physicians, there is something called compassion fatigue. And they're working really, really hard to continue to have that care and to want to see each body as a spiritual being, as a human being. So that's why I was so glad that you were able to come and just learn a little bit about these experiences of what is actually going on in the true front lines then. Anyone else before we go on to another question? Okay, so Jillian's going to take you a step further. If you were working with her, she's going to tell you what you would be wearing.
So this is the glamour shot. Actually, this was taken last night while I was at work. I am in between night shifts right now. The picture on the right side is from where I developed something called a pressure injury from some of my protective equipment earlier on in the pandemic. There's a variety of different kinds of lung protection that we can use. And I had issues with masks causing injuries that were so great that several days later, I had this red swollen spot across the bridge of my nose as my body was trying to heal the tissues that had been squished down for so long, because when you're taking care of somebody on ECMO, you don't leave that room unless there's somebody else who is ECMO trained at the bedside to watch for you. So I was not leaving those bedsides for hours and hours, and I got injuries from my protective equipment. But on the left side of the screens, you'll notice my hair is covered. I used to have some fun scrub caps out of an Alice in Wonderland pattern, among other things. But then I cut off most of my hair about a week and a half ago, and those don't fit anymore. So I've been wearing those lovely bouffant caps. And I'm wearing a couple different forms of eye protection. So you'll notice I have a face shield on. You can see the gray band that's held on by elastic. And I have some goggles on underneath technically I would be allowed by our policies to do one or the other. However, those are prescription goggles and I can't really see what I'm doing very well without glasses. And I prefer to be wearing my washable ones and not my nice ones under the face shield. And then the face shield also gives me even better protection from any droplets or flying bodily fluids, depending on how conscious somebody may or may not be and how with it and engaged with the world around them they might be. There is a lot of potential for different sources of bodily fluid contamination. And so you'll notice I'm wearing a gown and gloves as well. So COVID is primarily spread through droplets of various sizes in the air by speaking, coughing, sneezing, where there's not a barrier in place. But it can also be transferred in other ways. And oftentimes we're dealing really with people up close and very, very personal in a lot of ways where we want to make sure that we're not taking things home for our families.
And beyond droplet, it is airborne.
Yeah.
And that's why, and there's been some confusion around that. I think people maybe don't understand the difference. So when we're talking about droplet, that's kind of the estimate when someone sneezes, chew. Okay, 6 feet, as if the virus would know, okay, please stop there. Please, that's the end of the 2 yardsticks. And we know that's not actually, nature doesn't respect our inches and our meters. And it's actually airborne, and the particles can become so fine that they can go well beyond that and linger in a room. And so that's where there's been some misunderstanding. And if it was just droplet, we wouldn't be wearing that particular mask, right? So all of us know the difference and what we're supposed to wear depending on different diseases. So thank you so much, Jillian, for bringing that picture to life to show us. So Nathan, you want to talk?
Yeah, no, I was going to introduce this one. So I think it's really cool that we have some very, very recent graduates and graduates from the first class ever. That's awesome. So we have a lot of experience with people from Bethel. So I want to know, as a senior nursing student, and I see a lot of seniors and junior nursing majors here too, how did your undergrad at Bethel prepare you for what you've seen when working in a worldwide pandemic? And if there's anything that you think you just didn't feel like you could be prepared for, if you want to share that too. But how did Bethel specifically impact you guys?
Yeah, I was really contemplating this question just this morning. And I think I underestimated the amount of people who I would interact with on a daily basis, whether that's my patients if they're still awake or family members or anything like that, who have different beliefs about COVID than I do. And I think that's one of the hardest parts about my job. It really is like having those difficult conversations and feeling nearly antagonized when I present information to families or to patients. And I think that a lot of our education regarding like compassion and even cultural differences and things like that really prepared me to just, I would remind myself like I'm not the one in the bed. I think a lot of families' responses are out of like loss of control, right? They can't even come see their loved one who's in the hospital right now. So what are they thinking? They want to do everything they can. If that means doing something that, maybe isn't in our protocol for caring for COVID patients, I can understand that feeling of wanting to do everything. Just the ways that Bethel made me think, not just as like a medical nurse, but as someone who cares for a whole person and for a whole family unit too. I think that was really the biggest effect to me.
Thank you.
I would second that. I think one of the things that's really special about earning a nursing degree at Bethel is that you're getting a Bachelor of Science degree that's so focused on some of the technical aspects and the science and the mechanics while also being at a liberal arts school. And so you get this incredibly well-rounded education. I went through the humanities program even though I didn't have to. I had most of the other credits, but I wanted to do things that way. And that's just one example of seeing really that people are whole people. And I think that's a big part of the reason that I can still speak in full sentences at this point, and I haven't completely lost my mind. That and therapy and talking to other people and community, which is something I really had to learn how to do it at Bethel. I didn't grow up in Minnesota, so I was a little bit the odd one out at Bethel. And so I had to learn how to ask for help and how to find community in unfamiliar places and unfamiliar spaces. And so I think those aspects of earning my degree from Bethel specifically prepared me as much as a person can be prepared for something like this.
Yeah, I definitely would echo off of those. I think one thing that often kind of differentiating words is when I came to Bethel, I didn't just become a nurse who was also a Christian. Like, I truly became a Christian nurse, and just how that was at the core of everything that I did, all the care that I did. And I think that, you know, I graduated and I was 6 months into my job, and then they told us we'd be the COVID unit, and it was like, I barely learned, you know, how to really do med-surg nursing, and now we're the COVID unit that comes with so many unknowns and constant changing of policies. And it was really easy at first to get weary. I was also, my living situation wasn't the best. I was living with someone that decided she didn't feel safe living with a COVID nurse, and so she moved out. And just the loneliness, I think that brought with also working on the COVID floor. It was really easy to feel like just very defeated and very like lost. Like, God, where are you in the world right now? But I think my education at Bethel and just being like very foundational in my faith is like the main part of being able to care for others. I think that just put me in a unique position, and actually, you know, led to several conversations, like getting to share the gospel with my coworkers, like just kind of entering and like, hey, I know you're tired too, but like I have this God who like loves and cares for us and sees us right now, and just, you know, gives us strength. And so it's been really cool to see that, and just even further, you know, when the vaccines rolled out, and it seemed like every day COVID was more polarizing of what you believed or whether or not you were going to be vaccinated. And so it got to a point where we were very, very fatigued. We talk about compassion fatigue. Like, there was just like no pep in our step. We were just, really struggling, but caring for patients who had different beliefs as you and different beliefs about vaccinations and choosing to not be vaccinated. I think a lot of people in our unit who maybe don't have a faith really struggled with like caring with the same amount of compassion for those patients. But again, I just saw it as an opportunity to be like, look, this is like an image bearer of God, and like they matter just as much as someone who might agree more with my beliefs. And so I think that was really unique, just being able to continue to care for COVID patients with not even my own strength or my own energy, but just like really relying on God for that.
Next question.
So we have some awesome experienced nurses here. I think one of the things that we can do with this wealth of information is talk about some miscommunication and misinformation. So I think Jillian brought some slides that we can start with. So let's start there.
All right, so I have seen this pandemic through several phases from a lot of different points of view, from working in an outpatient position, taking phone calls where people are wondering, what do I need to do? Have I been exposed when COVID was brand new to us, to now doing a lot of times critical and end-of-life care. And one of the things that I've consistently heard is from younger people before and after vaccines, there's this myth that I'm young and strong, so I can just go on with life as usual. Our 27-year-old patient who passed away a couple days ago was previously healthy, had chosen not to be vaccinated, and she is no longer alive. And that one hit really close to home. But even if somebody is young and healthy and doesn't get very sick themselves, it's really, really important to get vaccinated to wear masks, because every time that you do that, you're taking action to protect other people and you're saving lives. You're just directly responsible for not passing on a virus that could potentially cause someone great harm or death. And one thing, and this, I put this together last night while I was working, and some of this information has changed even since then in the last 10 hours. But early on, the WHO, the World Health Organization, estimated that for every one person with COVID, they could infect an average of 1.4 to 2.4 people. For the Delta variant of the virus that causes COVID-19, that number has risen to be at least twice as many, from estimates ranging 5 to 9 people. Early data, it's going to be a couple of weeks before we really know more, but early data indicates that the Omicron variant is potentially even more contagious, maybe better able to evade some of the protective factors that we have to spread between people more easily. And the Omicron variant specifically has some mutations in the virus's genetic code that shows scientists these changes happened in people who were not vaccinated, probably who had an immune system that was compromised, even so they're not able to effectively mount a response. And so this is where, when we talk about herd immunity, where this becomes important is we need, as a group, to be as best protected as we can be, not only for to protect vulnerable people, but really for each and every one of us, because when we're protecting vulnerable people by reducing the spread of the virus, we're getting fewer chances to change and mutate, and it's going to cause less harm over time if we don't let it. So that's why it's really, really important for so many reasons, for young and healthy people, or not so young but otherwise healthy people, to get vaccinated, to continue to wear masks, to keep physical distance when you're socializing.
Because really, at the end of the day, even if you yourself will be fine if you get it, that doesn't guarantee that anybody you could pass it along to will be. You can see that time and time again. It's grandparents coming in because their grandkids gave them COVID or anything like that, and then they don't do well. They die. Quite honestly.
There are names that I will remember for the rest of my life of patients who died, particularly before vaccination. One who had several kids, one of whom was a nursing student about to graduate, who was my age at the time that her mom died after being on ECMO for more than 2 months. We finally made the decision to turn that machine off in concert with the family, and they passed away. A younger mom who was a transplant recipient, but got really sick with COVID, ended up dying while their youngest child celebrated a milestone birthday. And so even if maybe one of us might be okay, which isn't necessarily the case anymore, we can pass it on to other people who won't be.
No, I think one thing I heard in there is wear your mask. What if I don't want to? They don't work, do they?
Masks do work. They do. So Dr. Sandau talked about this a little bit earlier. There's been misconceptions around how the virus is transmitted. Is it passed on through droplets? Is it airborne? Well, it turns out it's both, and airborne is the more contagious of the two. Masks, however, do work, and I have a little pin for one of my bags that says, "My mask protects you, your mask protects me." And that's partly true, but you do get some protective benefit from wearing even a surgical mask, even when you're out in public. The biggest thing that masks do for us, COVID is sneaky. Like a lot of other respiratory illnesses, it is most contagious before you even know you have it. And so wearing a mask consistently, it's important because you're probably not going to know COVID if you have COVID when you're potentially the most dangerous to the people around you. So wearing a mask consistently means that if you do get infected, you're a lot less likely to pass on the virus because it is being physically blocked from leaving your body in a way that is most dangerous to other people. because the masks will catch a lot of it, especially if they're worn covering both your nose and your mouth, and they're fitted appropriately for your face. So masks make a big difference, and I cannot stress that enough.
I might have a little to add in this, and just saying that I don't know about the rest of the audience members, but I did not have a single respiratory illness last winter. I had my first cold about a month and a half ago. And, you know, I've conferred with area health services and other universities, and it was extremely quiet in the clinic with the general respiratory things that we typically see a lot of. And I really attribute that to both the distancing, but masking as well. And it's hard to hear people just really downplay the effectiveness of masking when, and I mean, influenza rates last winter were unbelievably low. Like, we didn't see a single case that we knew of, you know. We were seeing a pretty significant outbreak almost in some schools of influenza this year. And so it's hard to deny just those kinds of things to say that, you know, the distancing and the masking, it's very effective.
Yes, get your
Something
first shot as well.
Something I would just chime in with real quick is that, you know, I have yet to hear a compelling argument against masking, like, from anyone, because it's such an easy thing to do. And, you know, some people claim that, oh, it makes it hard to breathe, things like that. I mean, you look at like surgeons who are in the operating room all day, every day, and, you know, they've been wearing masks for, you know, 40 years. I mean, there's no compelling evidence that I can see that masking causes any adverse side effects. So it's such an easy thing to do. You can do to help other people. So why not do it? Even if it's, you know, 0.2% effective, that's still something you can do to contribute to other people not getting ill. It seems like a pretty, you know, harmless thing that can help a lot. So.
All right, so I suppose you guys convinced me that masks are okay. I guess I can get by with that. Well, what about this vaccine? It was just developed way too quickly, right?
So this is something that I specifically wanted to speak to because I will be very honest with you. When I heard that there was a vaccine coming out, or that it was in the works before we really got to that point last year in December, I was nervous. I was hesitant. I had a lot of questions. I am a nervous Nelly. I am anxious. Both, I have that in my personality. I have a clinical diagnosis of abnormal amounts of anxiety. And I was really uncomfortable with the idea of a vaccine that had come to market so quickly until I learned more about how that process works. So this is a wonderful graphic that I forget now where I got this from. It's in the presenter notes, I think. Where is that?
Nebraska.
Okay, University of Nebraska Medical School. And so it compares the timeline of traditional vaccine development and accelerated vaccine development. And there's a lot of things that I didn't know as a nurse. No corners were cut by vaccine developers. People weren't starting from scratch. We have been studying coronaviruses in detail of many types for over 50 years. mRNA vaccines have been studied for various viruses for over a decade. There was some really incredible collaboration to get the vaccine testing started and to get volunteers using networks that were already in place because of research that had been done around HIV and AIDS, transmission and vaccination against HIV. And so using those networks of communication that had been established, even if people hadn't been involved in the HIV research, we could use those models to communicate and to find volunteers who are willing to participate and willing to help with the vaccine development. And frankly, what it really comes down to is an unprecedented public health emergency called for and got an unprecedented level of response in terms of resources, both monetary, human, and teamwork. And so we're going to be coming up on my birthday soon, and my birthday present last year was the first of the Pfizer COVID vaccines left the plants in Michigan and were shipped out. And that happened the day before my birthday, and I could have cried for days. On this next slide, this is the first of my shots, and it's a little harder to tell in this picture, in part because of the glare, but I am crying because I'm so relieved, because when I got vaccinated, it was a weight off my shoulders to know how much safer I was, even though I was going to be continuing to go to work and to be exposed to COVID all the time. Because breaches in PPE do happen, and sometimes you find yourself getting sent home from work and having to change clothes in a parking garage in the middle of the night, because we didn't know what we didn't know, and that was early on in the pandemic. But I'm really grateful that we have the vaccines, because I feel so much safer knowing that I'm less likely to get sick, and I'm less likely to get somebody else sick or killed.
So just a little bit ago, Liz said that the rates of influenza have been way down since wearing masks and whatnot. So influenza, COVID, they're both respiratory stuff. It's just like the flu, isn't it? It's just the same thing.
Yeah, so this is something that I hear a lot, especially like young healthy people. But I mean, the fact is that COVID can actually be more contagious than the flu for a longer period of time. Something with COVID is that you can go asymptomatic, so showing no signs or symptoms but still be spreading it to people. COVID can spread more quickly than the flu. And there's a lot of similarities between symptoms of the flu and with COVID. However, COVID can actually result in severe illness. And it can be more likely to do that than from the flu. So some of these things would be like pneumonia, respiratory failure, having a stroke from clotting, or multi-organ failure, which have all been talked about today so far. The mortality rate of COVID is actually higher than the flu. So since December of 2019, the total number of COVID deaths has caused more deaths than the past 5 flu seasons combined. So there was 160,500 deaths from the flu since 2015, but since 2019, there's been 776,000 deaths. And every single one of those is a real human. And it's not just a number. It's a story that each one of us has. It's a nurse who held their hand for the last time. It's a real person, and you don't know if it could be you, and you don't know if it could be your family member. Yeah.
Well, now I'm getting all conflicted because I thought I heard that the mortality rate of this is super low. What's up with that?
Yeah, so I think when we're looking at COVID and the effects of COVID, it is so crucial to look past the point of the mortality rate. What can happen when you contract COVID is you might not just be sick for a week and then get better, but you might have long COVID symptoms. So I'll share my own experience in this. Is I got COVID last November. I tested positive. I just took like a saliva test at home because I was like, oh, it'd be smart to know like holidays are coming up. Like I'm just gonna take a saliva test just to be sure. And the next day it came back positive, and I was like shocked. That night it was like a light switch. Like I developed a ton of symptoms, like all of the classic COVID symptoms. And to this day, I can barely smell. And the smells that I do be able to smell are often distorted. So I smell a lot of garbage. I smell a lot of onions. I smell just like really weird things that shouldn't smell like that. And that's just the fact is that can happen. Maybe they call it long COVID, long-term loss of taste or smell. And really this can affect someone's health much more than just a physical health. It can affect it emotionally, socially, spiritually, even financially if you have to be out of work because of that. And for me, my emotional one is I see people have difficulty breathing every single day. I see people who are in bed and all they do is sit up, and suddenly they're requiring 6 more liters of oxygen because their lungs just can't keep up to that little thing. And that has caused a lot of anxiety for me with breathing. Since COVID, I've had like chronic congestion, and that constantly causes anxiety. Like, am I going to stop breathing? And I have to really like take some deep breaths and just like remember, like, I am still breathing, but it's crazy just how much an effect that has had on it. So here are some reported long-term COVID symptoms, and we won't go through all of these, but you know, ongoing shortness of breath, ongoing tiredness, fatigue, dizziness, lightheadedness. I'll share a quick story of my coworker, young and healthy. She got COVID, and she was out for like 2 months sick. She tried to come back to work, but the headaches, the dizziness, the inability to concentrate and look at the screen, inability to remember things. She was put on light duty, which is work restrictions, and was unable to follow through on that, and actually is now unemployed because of it. And so it's just goes to show you that even if you're just sick for a week and infectious, like you can be sick long term with these things.
Well, I think it's time for pop quiz. Wait, you're not in class. That's not fair. Nathan's going to guide us here. Okay. So today, December 2nd, what is our county's level of transmission today? You guys, low, moderate, substantial, or high? Chocolate for the prize. Anyone? Oh, he's running for the chocolate. So give a low, moderate, substantial, or high. Let's see. Anyone want to guess?
Just gotta guess.
I see some hands going up. I see some hands. Chocolate for the high. Here we go. Yes.
Who said hi?
She said hi. She said hi. Yeah. No.
Oh, I heard chocolate.
Yeah. Yeah. And therefore we should wear a mask in public spaces indoors. True or false, everyone? True.
I have a lot of chocolate to give out. Oh, man.
Yeah.
Oh, man.
I think we'll put the jar at the end. People can grab a chocolate as they leave. So thank you. And then Nathan's actually going to guide us with the CDC COVID data tracker in case you're not familiar with how to check out what is our level of transmission. And here we have, well, let's see. We've got 4 colors, and the color red is highlighted. Which county is that? Which one in the United States?
That right there is the entire United States. So
Oh my goodness.
as the entirety of the US, we're all in a high transmission state.
Mhm.
So on the CDC website, if you scroll down, you'll see this beautiful map of the US. That's a lot of red. That's a lot of areas that have very high transmission rates.
Mhm.
So on the CDC's website, you can go here for more information, and you can select county by county, state by state, and you can hover your mouse over and try to find your county. They also have a way that you can look state by state to make it a little bit easier.
Probably 0 people in those blue little
Yeah.
dots.
Probably.
Yeah.
Looking at central Montana.
Yeah.
Yeah, but I'm still like, Idaho is still like fully red.
Well,
Who lives in
yeah.
Idaho?
And Nebraska's not really reporting right now. So, yeah. Well, we better move on. So we know there's a lot of misinformation going around, right? And people are in echo chambers of their social media where they only hear what they want to hear, me included, right? We all need to step out of those echo chambers. And so how can people avoid misinformation? What are reputable sources? Who wants to take this one? Oh. Ivermectin here. Anyone been hearing about this? Yeah, so this is it's primarily for animals, I think, for deworming, and it's approved in humans for scabies. Some really discrete reasons that a human might take it. It is not recommended for COVID-19, and I would love to talk to you later, in terms of statistics and studies. So the majority of the studies that were showing benefit were retracted. As a researcher, you never want to have one of your studies retracted. That means you were unethical or you conducted improperly. And so I would love to talk to you if you have questions about this. I will absolutely help you work through this.
This is the one that we have lots of families ask us, well, will you please give them ivermectin? And we have to say, we can't. We have very specific protocols on how we treat critically ill COVID patients, and ivermectin is not approved for any of our uses. So I've constantly been like, sitting next to a doctor on the phone with a family member explaining why we can't give ivermectin. And the doctors feel like trash after that, right? Like they want to do everything they can to help these people and to help people get better. But we cannot give things that are not approved. And, you know, at the end of the day, it just simply does not work. So why would we? But yeah, we can definitely chat more about that.
Yeah, yeah. You hear that pressure over in New York, Dr. Bruske, for prescribing?
Actually, you know, I haven't heard people asking for it quite as much. I know there was recently in the news, like, was it a district attorney who sent a sheriff to the hospital to try and force doctors to prescribe it for patients, which is totally unethical. But no, it hands down, there's no evidence that it does anything. And why would you give something to someone that does nothing for their condition? It's
There are a couple, 3 trials enrolling, and this is how we decide whether or not our practice is evidence-based. We have studies that support it. So if you're interested in ivermectin and getting that, you enroll in a clinical trial. Go ahead, do it. But it's going to be in a safe manner, in a systematic manner, where your variables are controlled. At this point, we don't have enough level of evidence to recommend it. So. Okay. What's our next? Do we have one more misinfo, guys? What's our next thing here? Oh, well, who is trustworthy?
So this is something for all of us to be thinking about, whether we work in healthcare as medical professionals or not. And I kid you not, there is an acronym that was developed by a graduate student in the course of their studies that spells out crap with 2 A's to ask yourself when you're running through information. Currency, is it up to date? Relevance, is this related to my question? Who's the intended audience? Authority, who wrote this? Are they qualified to speak on this? Is there contact information for the person who's sharing this? Does the URL itself tell me anything? Is it ending in .org, .gov? Where is this information coming from? Accuracy, asking specifically, where does this come from? Is this supported by evidence? Has this information been reviewed? How so? And purpose, at the end of the day, what is this, whatever we're looking at the credibility of a statement or a piece of information, what is this trying to accomplish? Do the authors or the speakers make their intent clear? Is the point of view objective? And what are the biases, including what are our biases? Not, are there any? There are. We all come into this, whatever the situation is, we all come in with assumptions. And this is something that we do as clinicians all the time, thinking about levels of evidence, whether it's for COVID care or for other medical interventions or situations, asking ourselves, what's the level of evidence? And expertise is part of that. But you also have to weigh expertise against things like consensus and trials and studies and research that has been done.
I'm so glad you brought that up, levels of evidence. So professional organizations will actually provide guidelines based on level of evidence. And so when they have a guideline and it says should or strongly encouraged, that is standard of practice. That means as clinicians, we do it. And so the CDC, they're not a legal body. They can't tell you, you must do this legally. So when the CDC says you should or strongly encourage, that's as strong as they can give. And so if we don't do that for us as clinicians, it would be potentially low standard of practice, potentially litigation. We're not following the guidelines and standard of practice. And so I thought that might be helpful for you who are not in healthcare to understand when you hear that, that's what that means.
And can I just start with something?
Sure. Yeah.
And I just got a practice alert from my main professional organization, the American Association of Critical Care Nurses, which administers the board certification exam I took to have the CCRN credential. They also credential nurse practitioners in acute care settings, among other things. Important, reputable body. And I just got a practice alert about inpatient heart monitoring from, among other people, Dr. Sandau, the team that she worked with, as part of the study that was done with the American Heart Association about best practices there. So it happens all the time all around us that we're on the lookout for what's the best thing we can do and how do we know that that's the best thing.
I guess I do kind of want to touch on the phrase like doing your own research for a moment. I think aside from a few in the room, like we're not like, trained scientists who are running scientific methods and testing theories all the time, right? And like that's the research we're talking about when we're reading these articles and finding new evidence-based practices and things like that. So I think the best that any of us can do as far as our own research goes, and I include myself in that because I too have not dedicated my life to research, right? Like I'm a bedside nurse, is to evaluate all of your sources, right? And not always listen to one side. And I'm guilty of that too, right? Like I was talking to a friend once and he, we were talking about his decision to not be vaccinated and things like that. And, I was just pointing out how the importance of, gathering information from both sides and making your own evaluation after that. And he said, well, you do that too, just on the other end. I said, okay, you're right. If that's completely true, I have surrounded myself in my own echo chamber of people who believe the same as me. So I think recognizing your biases and just getting information from every source and whether or not you agree with it to like immerse yourself in that, because then you can make educated decisions for yourself and your own healthcare and things like that, but also trust the people who are doing that research because they've dedicated their lives to that. So they're not trying to fool you. That's their livelihood. That's their life. Like you said, to get your research retracted is is embarrassing. So like they have their own rapport on the line as well.
So next for our community. So in order to improve outcomes, we need to measure them. And so it's wonderful that we have a dashboard with some data for our community here at Bethel.
So Nathan's got one more pop quiz for you guys. So we see this weird spike right here, and that date under there is 11/29 of this year. Can anyone think of why that might be so elevated right there? And this is our positive cases for that day. Thanksgiving, I heard it.
Yeah.
Yes. So we saw an increase in cases on Bethel's campus after Thanksgiving.
Mm-hmm. So we just want to end with the last couple of questions. How would you like us to pull together as a community to be well and be protected and protect others? And also that kind of goes into how can we support you as well? We're so thankful for the work that you are doing.
I guess just in brief, just love each other. Like, choosing to be vaccinated is not only protecting yourself, but it's protecting everyone around you. And that is a way of saying, like, I love you and I care about you and about my community.
I think the phrase that's been brought up, rather than do your own research, do be educating yourself, asking sincere questions, keeping an open mind. Wearing a mask is a simple thing to do. I will say, as a person who has a lot of anxiety with PTSD, sometimes it can be really uncomfortable to have something on my face, and I don't love that. And in that moment, I stop and I center myself, and I do some of the things that I learned about how to help myself calm down if I feel like I'm having a panic attack. If I need to go outside and away from other people, then I do the best I can to make that happen. But, it's such a small thing for me to wear this mask, and it means that I am saying, I care about you. I want to protect you, to every single person in this room. Because if I weren't wearing a mask and I were infected, I could be behind COVID in the air for hours.
And I would say as the Bethel community specifically, test and encourage friends who are complaining of there's so many things about this virus that are so cruel, and one of them is it does not present in a way that you can go, oh, that looks like COVID. I mean, this week, one of the gals that came in just said, I just think it's a migraine. She's vaccinated, she had COVID. Another person said, I'm pretty sure it's just allergies. I can't remember if that one was vaccinated, but it was COVID. And so people reason away these symptoms. Just encourage, anybody that makes comments to you, go get tested, because thankfully the state has agreed now to extend free testing to us beyond 2021. We thought it might end at the end of this year, but we have adequate tests. So I would just keep that in mind, that you can always walk over to health services and get tested.
I'd say that's the biggest way to, first of all, be selfless. And that's the biggest word that I've been thinking of recently regarding the masking and vaccination. Even if it's not for yourself, it's for other people. And it's not that hard, so just be selfless and think of others in how you go about your life. yeah, I think, that's the biggest way to, and help us out too, is to be vaccinated.
I just want to make sure and give a shout out to let you guys know that there's a podcast coming from one of your own senior students at Bethel. Community health student Sarah Zelenga is releasing 5 episodes called Catch COVID, and it'll be available on Spotify and iTunes. So look for posters here next week. That'll be starting on the 9th then, where she's interviewing experts with tough questions then. So we got to the part of Q&A, and I know that some people might need to leave. We have some questions in the bucket, and I want to assure you that you can contact me if you have really specific questions, for example, or you want to look at a study and say, well, I found this study that supports the opposite of what you said. Let's talk. You want to talk specifically about vaccine side effects? I'm happy to talk with you. So I'm Kate-Sandau at Bethel.edu. And if you want to talk to a midwife about the myths of that you're hearing as well about fertility, you can talk to Brooke Eiskens, one of the midwives in our nursing department as well.
I had a comment I wanted to make real quick. Do we ever talk about the monoclonal antibodies? Because I think that's a good point.
Take it away.
So, I know there's been a lot of discussion of the monoclonal antibodies, and some people feel that it's, a way that, oh, well, I got COVID. Oh, I can go into the hospital and get this therapy and it's taken care of. And I kind of want to dispel that because I wanted to make sure people are aware that, monoclonal antibodies decrease your risk of, fatality from COVID by, a substantial amount, but that's only for the original variant of COVID. Whenever you have changes in the spike protein on the actual COVID virus, you are no longer attacking that virus when you use the monoclonal antibody, because monoclonal antibodies are specific for a very particular type of spike protein. And so you're not protecting yourself against the variants with that. And additionally, it's so late to the game. Like the best thing in medicine is prevention. You don't want to get sick in the first place. And, relying on things like monoclonal antibodies or ivermectin or really any of these, secondary measures is essentially, like allowing yourself to get burned in a house fire, saying, oh, they're going to put a skin graft on me later. It's like, you're not really focusing on preventing the harm from occurring. And that's really what we would like to do in the, public health sector. And, I think it's really important to realize that monoclonal antibodies aren't really protecting you. They're a stopgap that we can do when you're sick. They don't keep you from getting sick, and they don't always work. And you can still get all these long COVID symptoms and stuff. So I wanted to make sure that we mentioned that.
Thank you. Yeah, good point. Thank you so much for joining us all the way from New York, Dr. Bruske.
Thank you.
We're so proud of our grads, all of them. And we just want to thank them for coming and sharing their time with us today, because we know that we know your time is valuable. We know your energy is limited, and we are just very grateful for you and the work that you continue to do, all of you, whether you're outpatient or inpatient or physician or nurses or students. We thank you so much.